hospital computer can fail without a single light going out. The operating theatre is still there, the laboratory machines still run, doctors and nurses still know their work, yet a patient can wait longer because modern hospital care moves through a chain of connected information systems. That is the useful lesson from a computer outage that affected Waikato Hospital and the hospitals in Thames, Kuiti, Tokoroa and Taumarunui on July 22, 2026. One break can reach test results, patient histories, pages, clinical notes, and surgery lists because a digital hospital is not a filing cabinet. It is closer to a nervous system. Follow a patient with chest pain through the front door. Before treatment begins, staff need to be sure they have the right person. They may use the patient's National Health Index number, a unique identifier used across New Zealand's health system. They need allergies, medicines, earlier diagnoses and recent visits. A clinician orders blood tests and perhaps a scan. The laboratory and imaging teams receive those requests. Results return to the clinical team. Someone may need to call another specialist. A theatre may need to be booked. Every handover depends on information arriving at the right place, attached to the right person, at the right time. Paper can carry some of that work. It cannot instantly rebuild the whole chain. During the Waikato outage, staff could use some paper reports, but recent artificial intelligence transcribed reports could not be reached. Test results took longer. Paging did not work. Some surgery was delayed, and emergency departments had longer waits. Health New Zealand said safe patient care continued, but the disruption showed how many separate actions had come to depend on digital access. This situation has a long New Zealand history. For years, different parts of the health system bought and developed systems for their own needs. Hospitals, general practices, laboratories, pharmacies, and specialist services did not all begin with one national patient record. Useful information grew in different places, in different formats, under different organizations. An independent review in 2015 recommended a single electronic health record and said it could improve care coordination, especially for people with several long-term conditions. 6 years later, the National Health Data Strategy still described a slow and siloed move from paper to digital records. It said aging technology, different versions of important applications, weak network capacity, and information that was hard to share were reducing productivity and increasing risk. The phrase single record can create the wrong picture. It does not always mean that every fact about a patient sits inside one giant computer. A modern shared view can collect information from many sources and make it appear together when a clinician needs it. The information may still live in several systems behind the screen. That design has a great benefit. A doctor in one place can see knowledge created somewhere else. The patient does not have to remember every date, medicine, and test while sick or frightened. Repeated work can be reduced, and a dangerous detail can travel with the person. Connection also creates dependence. If a local application stops, one task may fail. If a shared login, network, clinical portal, or connection between systems stops, many tasks can slow together. The same bridge that lets information travel widely can become a point that many services need. Paper was not automatically safer. It could be lost, delayed, copied badly, or trapped in one building. It means that convenience and resilience have to be designed together. New Zealand's 2021 health service standards made that idea practical. They expected providers to test backup records at planned intervals and update disaster recovery and business continuity plans. A backup saves information. A continuity plan explains how people will work while normal tools are unavailable. Those are different jobs. Think again about the patient with chest pain. A backup may protect an earlier laboratory report. The continuity plan must answer the new questions created during the outage. How will a new test be ordered? Where will its result appear? How will an urgent specialist be contacted if paging is down? Who will later enter the paper note into the permanent record? How will staff make sure the patient is not given the same medicine twice during the changeover? Good preparation is deliberately ordinary. There are printed forms in known places. Staff practice downtime procedures before an emergency. Critical contact lists remain available without the main system. Work created on paper is numbered, protected, and later reconciled with the digital record. The safest fallback is not a dusty folder that nobody has opened for 5 years. It is a smaller working system that people recognize under pressure. The patient has a modest role too. Keeping an up-to-date list of medicines, doses, allergies, major conditions, and emergency contacts can help when a usual record is slow to arrive. It does not replace the clinical record, and no sick person should be blamed for not carrying perfect information. It simply gives the care team another safe starting point. A National Digital Investment Plan published in May 2026 proposed a more connected health system. The goal is reasonable. Information should follow the patient instead of making the patient carry the whole story between services. The Waikato outage reveals the second half of that promise. Information must follow the patient when the main screen is available, and care must still move when it is not. A hospital's nervous system does not need to be awake every second to be useful, but when it sleeps, the rest of the body needs to know how to keep breathing.